Yeah, we are honored to have all of you today for this panel discussion on COVID-19 today. The world is at an unprecedented situation. It's like a black swan movement, and we are fighting with a known virus with many unknowns about management and diagnosis and things like that. And being in India, so we are one stage behind what our European counterparts are. So they are almost in stage 3 in epidemic phase. So, and today's discussion is basically to take their experience and insights and absorb them and learn how to handle situation in our countries. So we have panelists from 2 continents, and we have participants from nearly 5 continents and more than 15 countries, around almost 8,000 participant registrations we had. So we try to take our European experience and join our Indian knowledge and bring out some conclusions so that collectively we can handle this pandemic effectively and we can treat our patients effectively. So for our participants' sake, I would like to introduce our panelists. So today we have Dr. Kevin Reynard, Medical Director, Elective and Emergency Improvement, NHS England. And we have Dr. Andrew Valence Owen, Medicover Group Chief Medical Officer, Chairman of UK's Private Healthcare Information Network, and Dr. Bala Venkat, Head of Anesthesia, Ganga Hospital, Coimbatore, India. Dr. Jose Chaco, Head of Critical Care Department, Narayana Health Institute, Bangalore, India. Dr. Subramanian Swaminathan, Senior Consultant, Infectious Diseases and Secretary, Clinical Infectious Diseases Society of India. And myself, Dr. Sharath, Interventional Cardiologist from Medicover Hospitals. My colleague, Dr. Ghanshyam, Head of the Department, Critical Care Medicine, Medicover Hospitals. So without wasting time, we'll go to discussion. So we'll start with the emergency medicine department. See, today for our hospitals, the only influx is emergency department. We closed all electives here in India, of course, also in other places, most of the countries. The only influx is emergency department. And so being in India, so restructuring our infrastructure, realigning our human resources is the very, very important thing, which we are supposed to do to handle this crisis. So Dr. Kevin will share his thoughts about how they did in UK about restructuring and realigning their manpower resources in emergency medicine department. Dr. Kevin, over to you.
Thanks very much, and good afternoon from to India from a good morning in England. I would just like to pick up on a few issues relating to the emergency department. My clinical role is as an emergency physician in England, and we are now probably at a stage where our numbers of attendances are plateauing, having seen a rapid rise over the last 2 weeks. We thought initially that as long as we were ready for patients coming in with fever and respiratory symptoms, we'd be okay, and we would be able to sort patients into COVID patients or non-COVID fairly easily. But that was tripped up on our first 2 COVID patients who were both diagnosed on CT-KUBs when being investigated for renal colic. We've seen many COVID mimics so far. So we have tried to divide our department into hot and cold areas based on quite loose terms. So we are placing all patients with respiratory presentations and all those with a history of fever into our hot area, where we are isolating patients in that area, and we're managing all our other patients in our cold area. Interestingly, our number of cold attendances has plummeted. We are now seeing approximately half the number of patients in total that we were seeing before the pandemic started. We've just had some interesting figures released in the UK, which shows that our whole cause deaths within the UK are at their highest level since certainly over the past 10 years. And only half of the increase at the moment seems to be attributable to COVID-19. So that suggests to me that there are an awful lot of people who aren't accessing emergency services when they have a serious condition. I think that's an understandable behaviour by the public, but we're now trying to get that message over to the general public to make sure that they do come to hospital still if they've got a serious healthcare problem, and not be too frightened of catching COVID in hospital. In terms of how we've arranged our department, let me just see if I can show you a slide of the layout of our department. And just wait for permission to share my screen. Thank you. So hopefully people are able to see my screen now. So we have a fairly large emergency department. We have in total roughly 80 trolleys within our department, and you can see that the blue is our cold area and the red is our hot area. So we've got a minority of our area assigned to cold. We've been very careful to make sure that we don't contaminate the areas within the department. The blue rectangle you can see on the bottom right is an area where, in theory, there is some mixing, but subsequently we've changed that to an entire.
Sorry to interrupt, but I don't. We are not seeing your slide, so.
Oh.
Okay.
I will. Let me just come back to. I'll just talk to the procedure then, rather, if you can't see my slide. So roughly 2/3 of our department is a hot area and 1/3 cold. We have found that this to be about the appropriate split for the patient numbers that we have coming through. One of the really big issues for us has been about personal protective equipment, and the supplies of this within the UK are never off our TV screens and on our newspapers. There's masses of PPE coming into the country, it seems, or we're told so, but the supply chain to get it to the front line isn't working particularly well. Because of this, we've been really careful about how we staff our hot areas, and we start with the minimum number of staff possible within that hot area, and then we escalate staff into that area from our cold area as we need to have more staff in there, rather than just split the staff up at the start of the shift and get them to go into the hot area.
Kevin, just a small query. Since we are seeing a lot of atypical presentations, and at the first instance that a patient walks into the ER, you won't know whether it's coming with COVID or non-COVID. Have you made it mandatory that everybody who is working in the ER should be in full PPE? Because
we don't have everybody in full PPE. We have a forward triage that's occurring before patients come into the ED, where that can either be performed by the ambulance crew, who then would leave their patients in the ambulance and would come into the department and speak to a senior nurse, and they would direct them where to take their patient. And for walk-in patients, we're seeing them right at the front door where we establish if they've got a respiratory history, a history of fever, or a current fever. And if they have any of those things, then they go through into our hot area for their further assessment. In our hot area, people are wearing full PPE. In our cold area, people are just wearing surgical masks, aprons and gloves. There is some disquiet in the UK about whether that's the appropriate level of PPE. And there's perhaps a feeling that our PPE guidance is more based on what's available rather than what's the best level of PPE. One of the really important things about PPE is to remember it's there to protect the healthcare professional. And as such, they can continue to wear it for a whole session within an area and don't need to change it between patients unless they've been involved in a procedure where they're likely to become heavily contaminated. So an aerosol generating procedure.
So just asking both Kevin and the other panelists, Dr. Jose or Dr. Subramaniam. See, normally when you get a patient in the emergency room, at the first instance, you wouldn't know that the patient, we are going purely by the clinical symptomatology. So before we label him as a probable COVID positive, COVID negative, what are the key points that you would look at? And, what is the average duration that somebody would need to, I know there's no definite answer, but what duration are you looking at before you can say that somebody belongs to a, he's probably non-COVID, so I can move him to a safe zone?
So I think that for most patients who end up in the cold zone, that's done at the very first assessment, which takes a matter of minutes. We are managing our patients in our hot zone in individual rooms. So once they've gone into the hot zone, they tend to stay there till either they're admitted to hospital or to the general beds, or they go home.
Dr. Jules, your thoughts? Most of the emergency rooms in India don't have the kind of facilities, where we have individual rooms. So, what do you think is the reason time, or what are the features that you would look at before you would say probably, okay, this guy may not be a COVID?
I think the first and most important thing to do is at the point of first contact, you take a short history, firstly regarding symptoms, the classical symptoms of COVID as we know, fever, cough, and breathlessness. And secondly, it's important to take history of possible contact, especially in India, where most cases are still from contact. So you need to get that history. And this can be done in the first couple of minutes. And if there is any suspicion of possible COVID-19 as being the problem, then obviously you need to take this patient to an area, a protected area where there is protection for the staff as well, and they evaluate this patient further for the likelihood of COVID and proceed from there on. That's the system that we follow in our hospital as well. So initial question, and then if there is suspicion, take them to a protected area where you carry out further examination with PPE, and then come to a definitive conclusion as to whether how high the degree of suspicion may be.
Yes, so we are very similar to that in that our aim is to over triage into the hot area. We don't want our staff who haven't got full PPE being exposed to COVID-19 patients. So we do exactly the same thing, a brief history and checking the temperature.
We have a PCR testing and antibody testing. So antibody testing will give us a rapid information, but PCR testing is nearly, in India at least, it is taking 24 hours per test report. So I mean, in UK, so how are you using this antibody test? How are you using antibody tests to segregate the patient?
So we're still not using antibody tests in the UK, and that's because I think the feeling from our scientific advisors is that they're not adequately sensitive or specific to be able to give us the sort of guarantees that people are looking for. We have the same issues with the PCR, that it's taking roughly 24 hours to get patients all in the same bay, and we keep the people who are definitely COVID negatively cohort as well. We recognise though that the PCR test in itself isn't entirely successful. We have a number of patients who we strongly believe have COVID and their PCR has been negative. So we also are using typical radiology changes either on chest X-ray or CT chest to be a diagnostic feature.
Dr. Subramaniam, see, as a clinician, we agree that getting a microbiological result is going to take some time. So that worry, are we dealing with the COVID is always going to be there. So are there any blood investigation, something which can strongly point to that yes, this could be a possible COVID?
Okay, first disclaimer, I'm not a microbiologist, I'm an infectious disease physician, so I'm a clinician as well. So let me explain it like this. I think we need to learn from the Taiwanese model. Their experience with SARS is extremely instructive in ensuring that not only did they not only were they successfully able to reduce cross infections within the hospital, they also brought down risk to the caregiver by a huge amount. And their traffic control board approach is actually a very, very sensible one. So my point is, I don't believe in labeling somebody as COVID or non-COVID, because the problem is this: you label them as non-COVID and 3 days later they do end up being COVID, then what's the point in all of this? The concern is about transmission. So the triaging should be based on the risk of transmission and the risk. So what we have done is we have cut our ER into two. We can't have a situation where we have a person with a respiratory distress coming into a general ER and cough and sneeze and have an emergency intubation, which becomes an aerosol generating procedure, and you have other emergency patients at the same time. You have a cardiologist next door trying to assist a patient who suffered a heart attack, and that just won't do. So moving them to another area after that somehow doesn't strike me as the best use of resources. We have actually created a separate area where all our respiratory distress go, with the understanding that some of those will not be COVID at all. Like for example, a DKA will end up there. We recently had a liver abscess which ended up there, but obviously it could be shunted off. And the point is, we have a halfway ICU where these kind of patients can be handled if they need to be fast-tracked, and we cannot exclude it. So the answer is, it has to be driven by the risk of transmission rather than the probability of them having infection. Yes, that's important, but the risk of transmission is what determines how you handle them. See, what your idea is to prevent transmission. So let's look at the risk of transmission and look at it. Like for example, if you have a person with a COVID who comes in with a heart attack and they're not really coughing, or a severe myocarditis and they're not coughing, their risk of aerosolization is going to be much less than somebody who has a bad pneumonia. So obviously both of those cannot be tried in the same place. Just food for thought. Now, second, as far as testing is concerned, let's not get too excited about the rapid test. Again, when we talk about rapid tests, there are both antigen and antibody-based tests. Fortunately, antigen tests are not out, and we still don't know where they're going to go. As far as the antibody-based tests are concerned, the evaluation has shown that in the first 7 days of illness, it performs pretty poorly. And the positivity starts rising by day 8 of symptoms. So that basically means that most of your patients who come into the ER, this is going to be a hopeless test. I think the way forward will be looking at something like LAMP, loop-mediated isothermal amplification technique, where your threshold of detection is going to be much lower, and it can even be run in 20 minutes. And this kind of technology can be easily set up in many hospitals. So I think LAMP may be a better option as compared to RT-PCR. RT-PCR, really the sensitivity is inadequate, especially in the early stages. So I am wholly unsatisfied with the RT-PCR. Yes, it's the best we have, but it's still a one-eyed man at best. I think LAMP will be a better option for us going forward, but for now we'll have to make do with this. And LAMP is not too far away, just so you know.
Yeah. Okay. So, with this discussion, I understand So it is better, we have to divide patients on symptoms basis and the possibility of transmission basis into COVID and non-COVID areas. Yes, does it make sense, to do antibody testing for non-COVID areas? With the discussion, I understand it won't make sense even antibody testing to, non-COVID areas. So, but
I'll put it like this. What is the role of antibody testing? If somebody is asymptomatic and again, it all depends on the kit as well. A lot of people have complained about the kits that have come from where. Let's not name anything. So a lot of people have complained about the quality of the kits and things like that. So that's a whole different discussion. I don't want to talk about it. Assume for the point of discussion that the kits actually do spectacularly well. There is no false positives, there's no false negatives, all those things. Even if that were so, basically it would be infection rather than new infection. So that's the only thing that will help. To me, the antibody-based test will be helpful in the second half. Towards the back end, if I want to triage my elective patients. So if I have elective patients coming in, let's say for an or even emergent patients coming in for surgery, if they are antibody positive and they don't have any COVID-related symptoms, at least 7-8 days into the illness, I know that these patients have already survived the COVID illness and hopefully they are immune, and therefore there is an element of safety there. Again, all these are conjectures. We need a lot more data to validate all these hypotheses.
Yeah. See, this brings me another question to me, right? If antibody test is positive for an elective case, which is going to operation theater or cath lab, so does it make sense to do a PCR test? And this PCR test, is it going to help us in terms of transmissibility?
No. At this point, no test makes sense. That's the honest truth. That's the problem. The point is, antibody-based tests are not going to pick up your incubation period patients, which are the most infective, and definitely you're not going to have antibodies. Second, even your PCR pickup in those kind of patients is going to be pretty poor. So I don't think you should be using testing as a strategy to find out. You need to have a set of precautions which are a basket of interventions which you do for everybody, and those who are high risk, you need to step it up. I think it will have to be that way. It can't be anything less than that bare minimum. For example, like in Singapore hospitals, everybody wears a triple layer face mask. It doesn't matter where you are in the hospital. If you're walking inside the hospital, no thyroid mask, by the way, if you know what I mean. The masks have to be on the nose bridge at all times. Yes, thank you. I'm home, so I'm not wearing a mask. So it has to be on the bridge of the nose and it does not move out of there. If you're going for lunch, the lunch is in a separate area. All your food is in a separate area where you can take off your mask, dispose it, have your meal, and then put on another clean mask, and that stays where it is. It doesn't matter if you have to answer a phone. And second, they are insanely anal about their hand hygiene compliance. To me, for a droplet-based precautions, these two are absolutely key for a non-aerosol generating area. For an aerosol generating area, obviously the threshold is much higher. So if we start cutting things up like that, it may make a little more sense, and that way we can also use your precious Ppe Usage a little more safely.
Yes, thank you. This question is quite pertinent because we are facing a problem in hospitals. Every consultant, who has a case for elective surgery, so they don't want to venture into surgery without having either antibody test or PCR test or blah blah blah. So this makes this is really giving us some conclusions, how to go about in these kind of cases.
Yeah, just taking this discussion further.
Can I just raise a question about testing, which is about staff testing? One of the issues we've got in the UK, I'm sure as Kevin will agree, is not always knowing whether someone who has cold symptoms has actually got COVID. And a lot of staff are therefore in quarantine from outside work. I mean, I know people who have got flatmates who have got a cold, who are quarantining themselves for maybe a week or two when they're needed on the front line. What is happening about testing of staff in India? Kevin, you may want to come in behind on this, but that's quite an issue for us.
Fortunately, our numbers are so low so far, and outside of certain real hotspots like say Bombay or Pune and things like that, the numbers are still pretty low. So as of right now, it's still very unstructured, which actually scares me a lot. And I mean, overall, I would rate the government's response to this as being reasonably good, much better than most other places that shall remain unlabeled. But having said that, I would say it's been pretty good. But my concern is that people are now starting to tilt at windmills. like was just mentioned. And my worry is if we are not very prudent about this, we're going to start losing our PPEs fairly quickly. But having said that, I think screening of the house staff is going to become a problem. In America, where they are overwhelmed, they're just doing twice daily temperature checks on all their staff and then asking them to report if they have symptoms and then going forward with that. See, the problem is this. The problem is we really don't have a great test. Like in the early phase, even your PCR test doesn't do very well. Lee Wenlian, and God bless him, he rested in peace. He had so many negative PCR, developed the pneumonia, and finally in the pneumonia they picked up the COVID. So what can we say? We know the PCR has limitations. I think the LAMP, hopefully, fingers crossed, the LAMP may be a much better option. I just checked it today. I believe there are at least 10 companies around the world which are in very advanced stages, one being in Pune apparently, amazing, which are close to rolling out a LAMP technology test. And it's going to be a lot less expensive and heck of a lot faster. And the threshold of detection, if it's really good, will be much, much lower. As compared to PCR, which is 100 copies per ml, this will be down to even a 1 copy per ml.
Just now we have understood the limitations of testing, but then again, coming back to the clinical management, right? And you can't have multiple zones where you can, keep these patients. So we need to have some way of, stratifying the risk of which patients would probably land up into the ICU, go onto the ventilator, or which patients would be stable. Are there anything which can, clinical or laboratory parameters which can tell us that this patient probably is somebody whom I should watch very, very careful, and this needs to go to my ICU, or this guy can't stay in the wards or in the step zones?
So risk stratification of patients with suspected COVID.
Dr. Jose, sir?
Yes, Ghanshyam. What we go by is, of course, the usual clinical presentation. The most prominent will be the way in which they are breathing, the effort that they make to breathe, use of accessory muscles. The oxygen saturation is a very important clue, probably because many of these patients, as you know, they have low saturation. They may be hypoxic, but still not very uncomfortable during the early phase of illness. So that's another thing that you would look for. And then, of course, the usual parameters, including heart rate, blood pressure. So you go by all these things and decide upon what level of care they may require. In general, our practice at least has been, if there is a strong suspicion, we have a designated area within the hospital where they go to. If we have a strong suspicion based on the history and the symptomatology, they go to a designated area of the hospital where we can ventilate them if required as well. You can offer them any level of support in that particular area. And in that area, we take adequate precautions for the staff involved as well. So as we discussed previously, initially it may not be very clear as to what the underlying problem may be. They may well be negative. They may well be non-COVID problems. But it may be a good option perhaps to cohort them, depending upon your circumstances, to a pre-specified area where you can step up the level of care to the desired level if it comes to that. At least that's the way we have been doing it in our hospital.
Just taking this a little further, sir. One of the major concerns has been the use of some kind of a respiratory support. Like we know that most of these patients can have difficulty and land up with respiratory failure. Now the concerns of the usage of high flow nasal cannulae or NIV. Now that has been a matter of debate. There are some literature which suggests that NIV can be used. Some say no, it cannot be used because it produces aerosol, so you need a negative pressure. But in a scenario where you have severe shortage of ventilators, what is your take on that? NIV, high flow?
Yes, it's a very important question. Thank you for asking this question, because this question has been asked, I think, by most people around the world as to whether you should use high flow nasal cannulae and non-invasive ventilation, including CPAP or positive pressure ventilation among these patients. The way I look at it, there is concerns both to the patient and to the caregiver with the use of these two modalities, and you need to be judicious when you use them. In terms of patient safety, The problem is, if it's a VC unit and if there are many patients, if you don't monitor these patients while they're on high flow cannulae or NIV, it is quite possible that they may deteriorate to a point, and you may well not be able to notice if you don't monitor them that closely, given that the number of staff members you have at a given point of time may not be adequate. It is possible that they may deteriorate to the point that you may have to scramble for intubation at the last minute, and this will compromise safety of the caregivers as well as safety of the patient as well, because if you do things in a hurry, there is always a higher possibility that things may go wrong. Second is, of course, the concern with aerosol generation with both these modalities. In fact, some of the at least critical care regulatory bodies, particularly the ANT6 statement, they recommend strongly against the use of NIV, citing the high incidence of aerosol generation with this technique. It is true that NIV can generate aerosols which will spread and might cause a higher risk to the staff involved with the care of such patients. There are expiratory valves, expiratory filters that you can use in the expiratory port, which might filter off the virus to some extent. So that is one of the options. And when you're using a high flow nasal cannula, it is important not to use very high flows, as in 50 to 60 liters. You keep the flow down to what is recommended is 20 to 30 liters. And if you use a surgical mask over the cannula, you can possibly reduce the contamination of the atmosphere with the aerosols.
Surgical mask over them.
Yes. I must say that we haven't done it so far, but there is a lot of promising anecdotal reports, at least, of people being prone while they are still awake, unintubated, and being comfortable, more comfortable with improvement in oxygen saturation. So that is one of the options that you could perhaps consider in some patients who can get themselves into the prone position without much struggle, and maybe you can assist them for some time to see if they improve or they're comfortable in that position and carry on with it. So, as I mentioned, we haven't done it so far, but we would certainly keep an open mind and consider it as one of the options if we get the appropriate patient.
Dr. Bala, another area of big concern and which has created a lot of anxiety, stress, and tension among many intensivists and anesthesiologists is the process of intubation. Emergency, elective. As an anesthesiologist, what would you suggest? I mean, how should one prepare for such a scenario? And well, not every center will have the most advanced airway techniques, but this might be needed anywhere. So, anything that you would suggest to people? How can we improvise?
Good afternoon, everyone. I thought I should start I will share this. Can I have the screen sharing enabled?
Screen sharing. So you just need to press the screen share button and still allow it. Okay.
It says that I need to have an access.
Yeah.
I've shared the screen. So I thought in the interesting stage of high number of COVID patients, and also the biggest scare is we need to consider every patient who is coming in as a potential COVID patient, since we are unsure about the tests and the phase in which they come to the hospital. We, the Ganga Medical Center and Hospital, it's a trauma unit. So every day we get roughly about 10 to 15 trauma even today. So it becomes imperative that we consider every patient coming in as a possible, potentially a COVID patient. And we thought we should make things safe for the anesthesiologist for intubation. So I just wanted to share, as you see in this slide, an acrylic box which has been made to intubate. So this we use for all the general anesthetic that we are doing now, and it's pretty cheap. That it costs about Indian rupees 8,000. And if you see the arm cover, it is disposable. That you see here, the arm cover is disposable. And when we buy this, the vendor gives me 100 sleeves set of this. So we use 3 sleeve sets for each patient, and this is completely covered. And so the anesthesiologist is introducing is both the hands inside, and it's completely covered. So the major advantage of this is, see, if you see him, this is it's not a COVID patient, but potential COVID patient. So he has got the mask with a shield and an N95 mask inside, and this box, the acrylic box, and this box is connected to a suction. So the aerosols that are generated here are sucked inside, and even if the patient coughs or bucks, it doesn't, the aerosols do not reach the atmosphere. I think this is something which probably could be adopted by every hospital in this country to make things extremely safe for the anesthesiologist. That's number one. Number two is the most experienced anesthesia. If it's a COVID patient or a potential COVID patient, I think the most experienced anesthesiologist should go for intubation. It's been proved that video laryngoscopy is better because your contact is less, and it's best to go with the PPE, and especially the mask. Very, very important that they go for the N95 mask P2, so that the aerosol generated is not inhaled inside. So a good PPE is definitely vital in a potential COVID or a COVID patient to decrease the propensity. So few things: PPE must, experienced anesthesiologist with single go, so aerosol is less. Number 3, video laryngoscopy is better than a normal laryngoscope. If you have a disposable blade for the video laryngoscope, is highly preferred. If not, the minute you use the blade has to be put into either hypochlorite or hydrogen peroxide or into a soap water, so that the others don't get it. The aerosol doesn't contaminate, and immediately we kill the virus. And the minute you intubate, the proximal end of the endotracheal tube is attached to the filter the minute you intubate. So this is very crucial, so that potentially the minute you intubate, the aerosols cannot come into the atmosphere. So we always use a HME filter in the proximal end of the endotracheal tube. And this patient is never ventilated until the cuff is inflated. Then when you start ventilation, you start with lower tidal volumes, and then you use low flows for this patient throughout the procedure. Another important thing is, once you have intubated the patient and connected to the anesthesia workstation or to the ventilator, you also have to make sure that 2 more HME filters are there, both on the inspiratory and the expiratory side of the circuit, where either it connects to the anesthesia machine or to the ventilator. So this is a double protection. So 3 HME filters per patient. It's a double protection to see that the contamination doesn't, aerosols do not enter either the machine or the ventilator. The next important thing is, unlike other general anesthesia, the minute you intubate, no way we need to disconnect these circuits intermittently, because it produces tremendous amount of aerosol. So and even if you want to disconnect, it should be done with the HME filter, the endotracheal tube HME filter. So the disconnection should be after the filter and not before the filter. These are few of the important steps that could be done to minimize the aerosol that is generated. And also, it's very clear that most of the anesthesiologists are aware that we go for a rapid sequence induction, so that the cough is very less. So these are some of the salient points I wanted to say. That if somebody is interested to buy this, this is manufactured in my city, Coimbatore, made. Once we use this, we remove off the sleeves. These are all disposable sleeves, and the entire cubicle can be sterilized to be used for the next patient. And the same thing is used again during extubation, so that again when the aerosol is generated. So something which I would wanted to share, which makes it more safer for us.
I totally agree with you, Dr. Bala. I mean, we have this box with us slightly, but we don't have the leaves with that. I just want to ask you one personal thing. Do you think the use of box makes it a little difficult to intubate, or do you think, the way we routinely intubate with no box or anything, is there any technical change that you need to do when you're using this box as far as intubation is concerned?
Yeah.
We have to unlearn and relearn.
Yeah, as when we started developing so can you hear me?
Yeah.
Hello?
Yeah, you're audible. You're audible.
Yeah. So when we started making this box, so we decided we have made now into 3 different boxes. So one for the obese patient, so it's small, moderate, and heavy build. So we have made these boxes into 3 different sizes, and because it also has to take into account the build of the patient. So we have designed it in 3 different based on the stature of the patient and also the height of that. For example, if the patient has got a difficult airway where you have to use something like a bougie or a stillet, so we have made the height into 80 centimeters by 60 centimeters. The height is 80 centimeters and width is 60 centimeters. With this, there is a free space available for the anesthesiologist to intubate. So it's not really difficult. So it's pretty easy. And since the whole material is transparent, it is like it's easy to intubate.
Yeah. Taking this further, Dr. Kevin, Dr. Bala, do you suggest that we have exclusive or identified teams who would be the exclusive teams who would do the airway securing the job of airway access whenever you are dealing with a COVID patient? And would you recommend to have a team which is assigned the job of only airway securing?
I think that for me the key is that people are very well trained to do this. This is doing things slightly differently and with much higher risks than standard. So the thing that we've done is rather than identify a particular small team, we've done extensive simulation training to make sure that all of the people who are going to be doing this do it the way that we want to. So we have an absolutely rigid procedure that people follow, and people aren't permitted to be part of the airway team until they've demonstrated in sim training that they can do it.
Yeah. So it looks, that makes sense. Probably
Yeah.
Dr. Bala can tell us, are you using this for every elective patient in your operation theater?
So now we have actually every anesthesiologist is very concerned in giving a general anesthetic for any patient. But the minute they see the temperature spiking even 1 degree for any patient, the first that goes in their mind is whether this could be a COVID patient. So now I think universally, since it's a reusable one, henceforth, until the pandemic gets over and it is declared that the pandemic is over, I think every other general anesthetic will have this this box.
Yes.
Yeah. Taking the discussion further, Dr. Joel, Dr. Subramaniam, how do you place hydroxychloroquine in the current pandemic? Is it a wonder drug? We are getting conflicting evidence.
Yeah, very important question that you raise, Ghanshyam. As you know, in India, the Indian Council of Medical Research recommends it not only for the treatment of patients with COVID, but also as prophylaxis for caregivers who are at risk. If you look at the data, there is no strong data one way or the other. In fact, from the team in France, which initially came up with this possibility that hydroxychloroquine may be effective, they have till today done 3 studies, but none of those 3 studies, if I may say so, has suggested strongly that it may be of benefit in patients with COVID. Their first study was a control study, but the control group was in some other hospital. And the only thing that they looked at in that first study was virological clearance. And the clinical outcomes of 6 patients in the treated group with hydroxychloroquine was not analyzed. Then subsequently, they published 2 case series, 80 patients first and then 1,000 plus patients in the second study without controls, which all suggested that there is virological clearance and possible clinical improvement as well. There is only one randomized control study from China which showed that there may be some symptomatic amelioration as well as early resolution of CT findings with the use of hydroxychloroquine. And there is some literature that is floating around of a paper that has been submitted to the NEJM from the US, which did a control study, and in fact it showed that escalation of respiratory support was more with the use of hydroxychloroquine. So the data is very much hazy at this point of time if you're looking for hard data, but there is a strong putative mechanism behind possible clinical benefit from hydroxychloroquine. It has there is a physiological rationale behind it. And in a desperate situation, when you don't have an effective treatment, you don't have evidence for any particular drug in this situation, and we have a very high mortality among patients who are seriously ill, it is natural that people reach out for desperate measures. And I suppose hydroxychloroquine is one of those drugs which can perhaps be tried, keeping in mind the possibility of harm as well. Harm as in not only with prolonged QT interval and ventricular arrhythmias, but also in regard to long-term harmful effects, including retinopathy. So these things will have to be balanced. I don't know about other hospitals in India, but in our hospitals, we don't use it as prophylaxis. But if the situation arises, we probably will use hydroxychloroquine in the treatment of seriously ill patients. As I mentioned, there is no hard evidence. I'm very keen to listen to what others may have to say in this matter as well.
Dr. Subramanian, your thoughts?
So I think he summarized it very nicely. I'm just going to go a little more into the putative mechanism that he alluded to. Because this was, people have been putting up pictures of screenshots of the Harrison's textbook 9th edition where it talked about this, and subsequent editions have not talked about this, and there's a reason for that. Because these putative mechanisms were mentioned as a possible role for dengue virus. It doesn't work. In vitro it works, in vivo it doesn't work. For influenza, randomized study showed it didn't work. For Ebola, didn't work. Chikungunya, it made it worse. So the problem is, chloroquine and hydroxychloroquine have this track record of having this amazing in vitro data and really poor in vivo efficacy. And studies have been either neutral or negative, and in that it really makes things bad. And as far as things are concerned, the RCT has come from my alma mater where I trained for my infectious diseases. And to me, it's the first RCT. Yes, it should be peer reviewed, and this concept of putting out data without peer review is something which is really deplorable. But if it's really true, the first RCT showing harm is a little bit of a concern. And I think HCQS has gained worldwide fame and popularity. This is, ironic, given that any other recommendation which had come from the same authority would have been treated with derision. But here we are, the same authority recommending HCQS, and everybody is gobbling away like, Tic Tacs. So that is ironic to say the least. And yes, I am not taking hydroxychloroquine. Our Clinical Infectious Disease Society of India is also not recommending hydroxychloroquine because we believe that the data is wholly inadequate at this point of time. At my hospital, yes, we have made it available, but we are not actively recommending it because it's a legal requirement for us to make it available. So we have made it available, but we are not actively recommending it. And lastly, Dr. Jagathkar came on, made a statement a couple of days ago, 6 days ago, where he said ICMR is not recommending hydroxychloroquine for treatment. So that is easily trackable.
Yeah. So Basically, in my understanding, hydroxychloroquine is it's more of it created an emotional effect on healthcare individuals. I feel politicians used it. I mean, it became so popular because of politicians, not because of medical personnel. But definitely, it showed a placebo effect, at least on many cardiologists. So,
can I ask? Are you using hydroxychloroquine or chloroquine in the UK, Kevin and Andrew?
No, I'm not aware that it's being used anywhere, and the current recommendations are that it shouldn't be used out with clinical trials.
Yeah.
Andrew, how about?
No, that's exactly the situation Kevin has stated.
Yeah. So I understand all panelists agree with, no hydroxychloroquine prophylaxis for healthcare professionals, at least. Yeah.
Just taking the therapeutic options a little further. Dr. Subramaniam, any role for antivirals? If so, which antivirals would you recommend?
Certainly, it's a viral infection, so I really hope we can have an antiviral. But the question is which one? None of them have any good data to back them one way or another. And we have tried a whole lot of stuff. There is some data on ribavirin. Somebody has been smart enough to try oseltamivir, which won't work. There is some data looking at boosted PIs, both darunavir cobicistat and also lopinavir ritonavir. The lopinavir ritonavir was a spectacular failure, but then the problem was they probably chose the wrong group of patients to do it. We know that once the patient is on a ventilator, the outcome is really bleak, even in the best of circumstances. So that's probably the wrong population to target. The intervention should be targeted at people who are destined for the ventilator but not yet on the ventilator. That's where you can really make a difference. I think unless we study it on that, we won't know. So whether it will make a difference or not, I don't know. The negative study is very disheartening. And the hydroxychloroquine, again, numerous studies are going on right now. We need larger data, better quality data. And for the simple reason of, data coming from one specific country should not sway us one way or another. I think we should take a lot of it with not just a pinch of salt, but with a bowl of salt. And favipiravir are interesting. We need more data. But I think we should also not forget about other unconventional options, including convalescent plasma, because this is not a new therapy. Remember, convalescent plasma is older than antimicrobial therapy, because we used to use anti-serum for pneumococcal pneumonia and things like that 100 years ago. And it has been used successfully to a limited extent in SARS, because it happened right at the end of SARS, and also to some extent with Ebola. So a problem is, how do we do that? How do we test for neutralizing antibody? Those are issues. But certainly that's also something we need to keep in mind. So till we get to an appropriate antiviral, maybe we should be looking at unconventional options.
Okay. Looking at the other aspects of the critical care management of severe COVID-19, Dr. Jose, where would you place the role of steroids? I mean, would you consider steroids, especially considering the fact that there seems to be a late cytokine storm that's been hailed as one of the reasons for unexplained deterioration. Similarly, IL-6 antagonists, steroids and IL-6 antagonists.
Yes, Ghanshyam. In fact, there's been a lot of very heated debate on the use of corticosteroids for COVID, particularly because in desperate situations, people tend to throw everything at the patient to try to get some sort of response. At the start, most of the regulatory bodies, WHO as well as the CDC, seem to recommend strongly against the use of corticosteroid, given the past poor experience, especially in SARS, wherein it was shown to increase viral replication and worsen clinical outcomes. So that was the suggestion that it might actually be harmful. But then we have seen in the last few weeks that there is an intense cytokine storm that happens in some patients, at least with COVID. And when this happens, they go down into a spiral from which they usually don't come back. So in this situation, this is exactly the situation where the anti-cytokine effect of corticosteroids might be useful. It hasn't been studied systematically so far, but then again, it is something that you need to consider, especially in patients who have a profound cytokine response. You might consider the use of corticosteroid, in my personal opinion. The other indication would be in patients who have shock, and obviously with bacterial infection and shock related to bacterial infection, there is enough evidence even at this time to suggest to support the use of hydrocortisone. So that's another indication for its use. And of course, in patients with asthma and COPD, you would obviously be using steroids as well. But as I mentioned, this very pronounced cytokine response is a situation wherein steroids may be helpful. We don't have data. We need to do more studies on this to confirm the findings. And you also asked about, specifically about IL-6 antagonist, tocilizumab, which has been recommended as one of the possible treatment options in patients with this cytokine response. Again, it's being studied in several clinical trials. We would very eagerly wait for the results of these studies. But at the moment, there is no strong suggestion to use tocilizumab in this situation. Intravenous immunoglobulin is another possible option, which again needs to be addressed in studies. So outside of studies, there is very little reason to use any of these. Corticosteroids, I would be tempted to use if I come across a patient with a very pronounced cytokine response. I would, of course, be interested in what others feel in this as well.
Yeah. Dr. Subramanian, your take on steroids?
Does the timing of steroids make a difference?
I think so. I think so. We need to find the sweet spot. See, the problem is we've been burned by the use of steroids in the past for other indications. So I think there's a natural reticence in recommending steroids. But the number of intensivists that I've talked to in the last 2 weeks or so, more and more of them are coming forward and saying that they would consider, or they are already using methylpred, not in 1 gram dose, but at least 60 milligrams dose for about 3 to 5 days in selected patients. See, the problem is that we put all of it as the same physiology into the same basket. They are not the same physiology. Burning could be due to, say, ARDS, it could be due to IL-6 storm, it could be due to an MAS, macrophage activation syndrome, it could be due to other organ systems failing, maybe a coronary event or whatever it is. I think to have a one-size-fits-all is probably very jejune, to say the least. I think we need to have a better understanding of the physiology and then see how this fits in. See, the same thing with tocilizumab. Obviously, if the IL-6 levels are not too high, I don't know if tocilizumab will make a big difference. So most people are saying, I do the IL-6 levels, see if they are going up, and if they reach a certain cutoff, I'd give tocilizumab. Would that make sense? Maybe. But having said that, unless you have a physiology-based approach like that, to try and hammer every nail with the biggest, hammer you can get is probably going to lead to a lot more harm.
Dr. Kevin, your thoughts on steroids?
We're certainly not using them routinely, and the only treatment in the UK that is currently recommended to be used outside clinical trials is oxygen.
So one more area of intense interest debate is the pathology where a lot of reports are coming about vascular thrombosis. I mean, there have been a few reports where acute pulmonary embolisms have been reported, and the debate of whether should they be given routine therapeutic anticoagulation. I mean, your views on that? Dr. George?
Yeah, it's again a very important question. As you rightly mentioned, intense prothrombogenic effects have been observed, at least in anecdotal reports in patients with COVID disease. And this has ranged from pulmonary embolism to strokes, acute myocardial infarctions, and so on, at least in anecdotal reports. In fact, there was a report from Netherlands the other day which mentioned about a more than 10% incidence of thrombotic events. These thrombotic events are due to endothelial changes firstly, and second because of the hypoxia itself, which is a prothrombotic condition. So in that situation, given all these prothrombotic circumstances that exist in patients with COVID, it makes rational sense to use anticoagulation. And in fact, there is one observational study from China that I came across. Wherein they compared patients who were given low molecular weight heparin or conventional heparin versus a control group. Of course, this is a retrospective study. A control group who did not have anticoagulation, and they found a much better 28-day survival among patients with a high score of thrombosis. So this study suggests that there may be possible benefit in the use of anticoagulants in patients with COVID. And I think the general recommendation has been that if there is a prothrombotic state with raised D-dimers, low fibrinogen levels, and if there is a possibility of secondary HLH as well, you should consider strongly the use of low molecular weight heparin. 40 milligrams once daily is, I think, the standard recommendation. But there is a school of thought that suggests that you might need to use a higher dose, a full anticoagulating dose as well. So I think on the whole, it makes sense to anticoagulate them. And if the renal function is intact, I would use enoxaparin or similar anticoagulant in a dose of 40 milligrams per day, which seems to be rational to me. As to whether full anticoagulation is required is an open question that depends on the clinical circumstances.
Yeah, so I'll come back to this healthcare workers thing. So, I mean, I understand from Dr. Subramanian's discussion, this periodic checkup of healthcare workers is really not going to help anyway. So, because there is no test which is really sensitive, and a test is not going to really tell us about the transmissibility. So, I mean, it's not going to really help us. But a healthcare worker who is already infected and treated, so when can we reabsorb them into work again? So this is something, very important, as Andrew mentioned. See, positivity in healthcare worker right now, at least in Indian scenario, if one healthcare worker is positive, that is leading to quarantine or isolation of at least 15 to 20 people in hospital. So, which is going to burden our healthcare system, and which is going to really affect our patient care and human resources. So, how can we handle this? Dr. Subramanian.
Okay.
Yeah.
Okay. Sorry, I wasn't sure who this was addressed to. So obviously, tough question. See, one option. See, basically, we need to rotate our manpower around so that we don't have everybody working all the time. Now, that's going to be a problem once we hit epidemic levels, like how most of the Western nations have had. But at this time, at least, it makes sense for us to divide our workforce. It's not the greatest system. But the problem is for us to have them off for 2 weeks is very difficult. We are gambling on the fact that more than 90% of the time the incubation period is less than 7 days. Fingers crossed. So obviously you'll have to come up with the solutions like that to try and see how you can rotate your manpower around so that you have less of them exposed all at the same time. That's number one. The second thing is obviously the culture of safety and being prepared for it has to come right now, even before you start having patients. After you have the patients, it's too late to make mistakes. So it's better to have as many drills as possible right now. Number three, your SOP should be very clear so that nobody has any questions about it. Fourth, I think we need to be a little careful about getting overboard about exposure. So unless it's a really high level exposure, getting petrified about it, the risk is fairly low. So we need to know how to triage for the possibility of exposure. And the most important thing there is making sure that all patients who have a respiratory system have a cough on, or have a mask on. That's probably the most important thing in reducing risk to healthcare. Not the healthcare worker wearing a mask is useful, but the coughing patient wearing a mask is critical. Now that, and also having specific SOPs for patients who are on ventilators and things like that will cut your risk. Lastly, if the situation gets out of hand, like how it is in Western Europe and possibly North America, I think we can't really be worried about how we can triage all of this and do everything. We may get to a situation where we get overwhelmed, where we just have to rely on good old-fashioned clinical decision making and temperature checks to decide what to do. I'm hoping we don't get to that kind of level, but it's worthwhile being prepared for that. But the point is the preparation starts now. Lastly, if you look at what the new CDC guidelines are, they are saying if you can get a negative PCR test, yippee. If you don't, if they've been asymptomatic for at least 3 days, allow them to get back to work in very brief terms. It's a little more complicated than that, but I think once you have an epidemic which kind of rolls over you, you don't have any other options other than making measures like this.
Yes. And Andrew, you have been a part of both the public and private healthcare systems. Now, preparing your manpower, your finances, your infrastructure at an administrative level, how difficult is that? See, as doctors, we always complain that the administration has not given us this, or this is not that. How difficult is that for you?
Well, obviously, we in Medicover we have hospitals with great staff who are doing the same work as people are doing in the public hospitals. What is happening in Europe, certainly in our other areas like Poland and Romania, is that the private hospitals are being used for non-COVID patients, and the public sector are taking all the COVID patients. And we're supporting the public sector by taking COVID patients. In the UK, the private hospitals have done the same thing, really. They've offered their services, like in India, cold elective surgery is being seriously reduced, urgent cases only. And the private hospitals are trying to take off the non-COVID patients. We don't tend to have emergency departments in private hospitals, but we'll take emergency admissions. I mean, that's what you would expect. Everyone is lending a hand to try and help where we're well ahead of you on the curve here in the UK. On the financial side, well, it's pretty grim for everybody, I think. Obviously, we're not doing normal work, and you have to accept that and get on with it and deliver the best healthcare you can where it's needed.
Yeah. This question is to all the panelists, right? Now, one of the major points that come to everybody's mind whenever we are dealing with such a pandemic is the PPE. Now, everybody demands for a PPE. Now, do we need to rationalize based upon the kind of exposure that somebody has, based upon the number of patients that somebody sees? Can we have a basic, I would say that the best would be if somebody has a complete bodysuit, a complete face shield, N95 mask. But again, that is not possible in every given scenario. So, how can we say, this is the basic that is needed in any given scenario, and this is the best if you have the resources, if you can, this is the best. So, to all the panelists, what would be the basic minimum that is needed? And does it really make a difference if you are surrounded by COVID patients, the kind of PPE you need, and if you're seeing only 1 or 2 patients, does it make a difference, the kind of PPE you need? I would just open to Dr. Bala, yes.
No, actually, since we work in a trauma unit, and as I said, we are getting patients every day, and then Tamil Nadu, the numbers are going high, and Coimbatore city is a hot spot with more cases coming in. So, the basic level, what I thought, in the emergency room or the triage area, every patient is considered as a potential COVID. And what is the basic minimum that you would offer for the casualty, both the medical officer, the staff, and the housekeeping? Few things we have made it very vital. Like every patient, the security who stands in the front of the emergency room, even before they come into the hospital, they are made to do the temperature scanning for every patient and the patient's attendant. So if the attendant, anybody who's having a temperature, they're first not even allowed inside the hospital. And in fact, the doctor goes out to see this patient. So this is step number 1. Step number 2, if the patient is found to have temperature with an injury, then an alert is given to the HICC and to the surgical consultant to know whether this needs to be managed immediately or it can wait for some time, and whether they can go back home, and if it's a simple fracture, so whether they can go back wait for 2 weeks, and then come back for the treatment. So this is in a way because the test was also inconclusive. So step number 1 is temperature monitoring before allowing the patient and the attendant inside. Step number 2 is if the patient has been found to have temperature, immediately the decision is taken based upon whether it needs a surgery or not. If you think it needs a surgery, then the HICC system is informed, and this patient goes through a separate protocol. First, a mask is put on this patient, and there is an awareness created among all the healthcare workers. And in the casualty or in the emergency room when they arrive, everyone has got the basic minimum thing. Number 1 is, as you rightly said, N95 mask P2 is not available. So we have there are local textile, the Citra is a textile research center. So a lot of indigenous masks, 3-layered masks have been made, and we see the porosity of that and the ability of it to prevent the viral load to come inside. So they wear a 3-layered mask. And we have also made another jugaad here. The LG Equipments in the city has made another equipment. It's a face shield, which costs only 55 rupees. And you wear it like a headgear, and then the whole sheet comes in down. So it costs 55 rupees. So all the people in the emergency room are wearing that, and the whole day they wear it and throw it off, and then it's disposed of. So these are some simple things that you could do and also they wear a glove. So these are basic minimum, 3-layered textured the mask. Number 2 is the headgear with a cover, and number 3 is the glove. So these are the basic mandatory things that we do in the routine day-to-day work. Even today, all the patients who are coming in, it's like that. And if we scale it up only if they potentially COVID or a COVID patient, then you go for the PPE. Otherwise, we can't afford PPE for all the cases.
Yeah. So as you said, optimizing PPE usage is a very, very important responsibility on all of us as a medical professionals, because we are at stage 2 now. God forbid if we go to stage 3, by that time all our PPEs are exhausted. So I mean, we are going to really, going to fall in a soup. So I think, it makes sense. Whatever inputs you have gave are really, wonderful and very useful.
Can I ask Kevin, what are you doing, Kevin, in your A&E department in the hot area?
So we're wearing face shields, FFP3 masks, surgical gowns, and double gloves.
That's a hot zone.
Hard zone.
Yeah. But are you in the same gear in the entire hospital, or? No.
So the level of PPE is related to the likely prevalence of COVID patients in those areas. So if it's a low risk area, such as our cold zone, we would be just wearing a surgical mask and a plastic apron and gloves, and being really careful about hand hygiene. I think one of the really key things for me is that the PPE that's worn should be proportionate to the risk, and it shouldn't depend on the grade of the person who's there. So it's really important that senior people role model this and don't perceive themselves or demonstrate that they believe that they're more valuable to the organisation and to healthcare than other people. Because we need to remember that all of the staff that we have are going home to their families, and they're worried about taking the virus home and infecting people. So it's part of being all in this together. And I think one of our overwhelming principles has been that we need to look after each other, and we need to be kind to people at work as well.
Yeah. Andrew, I think we are almost running out of time. I have
a couple of questions actually. Dr. Jose, I know you have been one of the most well-read persons. I mean, there is so much literature being thrown, in the last few days. Every day there's a new hypothesis which is being generated. Every day there's a new therapy that is being suggested. Now, how do we keep focus? Because it's also very important that we look at things which are practically possible, things which can actually work. So how does one focus on which literature to look at, which studies to actually try to see if that can be got into practice?
It's easier said than done, Ghanshyam. There is so much of stuff. If I switch on my phone, I am flooded with information of all sorts, and there is no way I can tell what is genuine, what is not genuine. And it's a real ordeal. So these days I keep my phone shut most of the time, and I look at things only that I really want to see. And one of the ways in which we sort of try to disseminate good information is we have our own critical care mailing list in which we discuss papers that are published or in the phase of publishing, and we discuss among ourselves people whom we know and whom we trust, who read through the whole literature and come up with what is good and what is not so good, to separate the signal from the noise. It is not easy, not at all, but you need to keep an open mind about what you come across and talk to people, try to identify the source from which it is coming, and try to get the best signals out, and try to not try to drown yourself in the noise. There is plenty of that at this point of time, as you rightly pointed out.
Dr. Subramaniam, one more question, right? As I said, yes, the government has been doing a good job. The numbers are not bad, and the lockdown has been extending. Now, the nightmare that we have been discussing is next 1 to 1.5 months, our monsoon is going to start. Your dengue is going to start. Your tropical infections are going to start. Are we looking at a greater disaster in the coming future?
See, please understand, while the lockdown is one measure, you can't get out of this with a lockdown. See, this is a pandemic and it's here to stay. The only way it will stop is when herd immunity is reached. Britain made a small mistake in their in the way they went about it. I think the Scandinavian countries are better example, Sweden and Norway, how they were able to keep their vulnerable in, and they got a young out, and they are progressing very well towards herd immunity. Germany as well has some very interesting ideas on all of these things. Problem is you can't protect people forever. This is going to go round and round like a Sputnik. Like China, who said EPBIR and all this chest beating, now they're realizing that the infection is coming back from other countries. And let's not go into that. Singapore is facing the same problem as well. Japan is facing the same problem as well. So you can't win this problem by locking up people. It's a temporizing measure to try and get other ways to handle the problem. So we had a very interesting webinar on this just now, meaning it concluded at 4 o'clock. One of my colleagues, as part of our SIDS webinar list, we had a last one on the way forward and the epidemiology part of it. And the point is, we need to understand what are the best options here. We have certain advantages. Remember that 50% of our population is 25 and younger, which basically means it's in the demographic where you have a very low risk. So we need to find a way of getting this demographic out and get them infected very quickly so that they contribute to the herd immunity. Now, what is the percentage of herd immunity is difficult to say. If it's about RO is about 2.8, it's about 64-65%. So if 50% is going to be from the young, we need another 15% from somebody else, and we can manage that. The point is, how are we going to do all of that is easier said than done. Obviously, it needs a lot of education, and right now the problem is we have a lot of talking heads who don't really understand all of this, and we need to be extremely cautious about this. And wishful thinking is nice, but it's not going to get us anywhere. This is a problem where we are up against. See, H1N1, none of us controlled it. It came to a stop in 2008, whatever it is, because it hit steady state levels, which is herd immunity, and that is 40%, right? RO 1.7, 40%. Same thing is going to happen with coronavirus. There is no magic by which it's going to go away. So let's just accept that, get our prep work done, and see what we need to do in terms of mitigation. And I'll tell you very honestly, with the information that I'm getting from the governmental sources, they have certain plans in place to try and see how we can leverage some of these strengths that we have. Yes, we have vulnerabilities, but we also have strengths. And the smart play is to make sure that we reduce our vulnerabilities and increase our, put out our strengths so that we can get away with less of a beating.
Can I just come in? I know you're about to finish, but I think Germany were lucky in that they had a very small cluster right at the beginning in Munich, and they were able to get started back in January. They also have a very strong biotech and diagnostics set up in Germany, and they have been testing furiously right from the start. And I think that has really helped. And their death rate at the moment, cross fingers, is much less. I mean, Italy has about 17,000 deaths, and Germany's only got about 2,000 deaths. So there'll be a lot to learn maybe later, but I do think that, and social isolation that they've practiced very early on as well. So I do think those three areas are very important, although I know the debate is going on about the value of testing.
Yeah. So I think we are coming to the end of the today's session. So, but I would like to put one last question to, all of us. See, I now, came to a conclusion that my practice pre-corona and post-corona, my clinical practice, my everyday things which I am going to do is completely different. So, how do you foresee how long we are going to continue this post-corona effect? In everything we do, clinical things, non-clinical things. Dr. Jose.
It all depends on how long this is going to go on for, how many weeks or months ahead are we going to go on like this. I sincerely hope, like all of us do, that it settles down from where we are in India at the moment, because it's very uncertain as to where we are heading at this point of time. Yes, we have learned a lot of lessons. We have learned to try to communicate, especially in our hospitals, try to communicate on the phone as much as possible, not to avoid face-to-face meetings, try to do things online as much as possible, try to do online meetings as much as possible. I think all these are positives that we could take out of this very tough situation that we are facing. And I think these positives should go on. These are the lessons that we learned, and I think we should stick to those lessons for the future as well. We don't need to be physically present everywhere. Of course, on a social scale, of course, it becomes necessary to be close to each other. But even then, it makes sense to try to do things without coming too much into contact, and especially with an epidemic going on the way it is. Yes, as to how long are we going to go on, I don't know the answer to that, unfortunately. It looks like it is going to be several weeks to several months at least before we have any kind of definitive answer to that question.
Can I just say, we obviously haven't mentioned a vaccine in this discussion, but there is a tremendous collaboration going on around the world, huge amount of money, Gates and people like that are putting money in. I think we will have a vaccine in weeks. I think it may take a year to get it into mass production, but I think that will be really important. But of course, we've seen in this pandemic that other things will come in the future, but we will be better prepared, hopefully, next time this happens. We will learn a lot, I think, from what people have been doing.
If I may make a quick point.
Yeah, Dr. Subramanian. Are there any changes which you made in this post-corona which are going to be permanent?
See, a couple of things. One, based on our own projections, we are expecting that in India at least it's going to take another 3 to 6 months of solid beating. Problem is that everybody is looking at only the corona. We are not looking at the economic impact of it. Yes. We're going to have another 9 to 12 months of economic downturn after that. So our economy, any economy for that matter, except one country, is probably not going to come back to ship shape till the end of 2021, which basically means the healthcare sector is also going to be massively impacted. It's going to mean a lot of changes for everybody, including you and me. So business as usual will not happen. because, insurance companies are going to be in trouble, the average man is going to be making a lot of money, there's going to be massive unemployment, there's going to be major issues. Second, there's also going to be changes in the way we start looking at things, especially in a country like India, where infection control has always been given a shot. Now, physicians and surgeons and who not is now forced to realize that you have to take responsibility. It's your life on the line, your backside on the line, and therefore you have to do things to keep yourself safe. And there will be a mandate because the society is going to hold you to a higher standard. We already know examples of outbreaks that happen because of poor infection control measures, and the society is going to hold you to a higher standard. And I think that's good, because if we want to progress along and hopefully meet up with Western standards in the future, this has to happen. So I look at it as a good thing. The last thing is that I think the government will now start having to look at investing in technology, in that we have tremendous strength. We don't even know how much bench strength we have in biotechnology and research. It's just that the Western world is also woefully unaware of how much strength we have. It's somehow very hidden, and the government is realizing that now. We have some brilliant minds in the country working in various areas. I don't want to mention any of these. But having said that, there's a lot of work happening. I am hoping that we'll start hearing some news in the next week or so. I am waiting to hear that because I'm aware of certain things happening. But these things will now become a formal issue, and India can actually lead in being able to do all these things for the Western world as well. We have strengths that they don't have, and the fact that we are not leveraging it because they're all fragmented and there's no unified command is a major problem. Lastly, I think this is where pandemic preparedness has to be a unified command. US paid the price for dismantling their pandemic preparedness ambassador, the head who was there, and now it's a fragmented thing and it's complete chaos. I think this kind of disaster management has to be centrally coordinated, and the fact that the government is now forced to realize that is a good thing, because the next time this happens, I hope we won't be in this kind of a chaotic situation.
Dr. Bala,
Can I ask a question?
Yeah.
I just wanted to know, when do you think we should start our elective work, like post-lockdown, elective surgery and elective work? How do we get into that, and what is the formula for that?
There's no magic formula. If you put it like this, the downturn of the pandemic, I estimate, is going to be between 3 to 6 months. The pessimistic answer is 3 months, because if it's 3 months, it means we're going to have a massacre. The optimistic is basically 6 months, which basically means we have a much more gentle and flatter curve, but that means more months of misery. So it's going to take time. Please hope for a longer period for revival, which is going to be more hardship for us, but it's going to be better for the society at large. But if that happens, you're going to see a shafting of elective work for a significant period of time. And this is going to become more and more challenging, because once we get to the upslope, that exponential phase, practically everybody who comes in will have to consider as COVID. And therefore, only emergency work will happen. And if it happens the way we expect it to, don't worry, you will all be repurposed for COVID work. I hope all of you saw the video of the neurosurgery department and COVID. And did you guys see that? It's viral on WhatsApp and all that. It's basically a Second World War movie with Hitler talking to his generals and all that stuff. If you haven't, you should see it. I think it's very instructive. Sorry to digress, but I think it's relevant.
Dr. Kevin, your final thoughts?
I think it's really difficult to know how things are going to go, because unfortunately this is a bald head rather than a crystal ball. My major concern is going to be that I think the societal and economic impacts on health from this are going to be much more of a problem than those caused directly by the virus. And we just have to hope that our governments are able to see us through this in the best way possible.
I think we are also going to see a lot of psychological issues coming up in the future, not only among the general public, but also among the healthcare workers.
Andrew. Dr. Andrew. So,
no, I tend to agree with all what's been said. I think I did speak a bit earlier about the hope for vaccine, and that will be very important as well. I think we are hoping that we are reaching a peak, and that our work on self-isolation and lockdown is beginning to have an effect here. But as others have said, I think it'll be months before we can begin to feel completely out of this, and hopefully not too big a second phase, which of course is the big worry after that.
Yeah, being an observer of both, government healthcare institutions as well as private healthcare institutions, how do you foresee this healthcare industry? When do you think it is going to get normalized?
Are you talking to me? I mean, well,
you're the guy.
I think for a start, there's going to be a different normal. I mean, extraordinary amount of work being done now online. I mean, this might well have a wider impact in years to come when much more information is being used online. A whole lot of learning being gained from what's happening. But normalization is, I think, a fair way away. Certainly for us, it's going to be a year at least, I think, before we're really beginning to get back. And then who knows what comes next?
Yeah. So, being a cardiologist, we are least bothered about infection. The only infection I know is infective endocarditis. So, I think the next infection I know now is the corona. So, I think that the only change which it brought in me, probably which is going to be permanent in me, is taking care of myself from infections. And also, see, I see most of the cardiologists, no cardiologists wear even mask or, cap in cath lab. So that is one thing which is going to happen, at least in cardiology practice and probably even in anesthesia practices and most of the doctors' practices. So which is going to be permanent. Yeah, there are a lot more which may not be permanent. And see, today's discussion was wonderful, and all our panelists really busted many myths of this COVID, and many facts came out, and there are still many unknowns about these infections in terms of how long it is going to stay in our countries, and how long it is going to cause economic impact. So all these things should come up. Time only will tell us, when we are going to come out of this. Yeah, of course, the good hope which Andrew gave us is the vaccine, and if that comes, probably. I don't know when it comes, but if that comes, probably we may go back to what we were, that is pre-corona. So all of us will hope for that, and I think we can wrap up with this.
Stay safe, gentlemen.
Thank you. Thank you all.
Thanks, everyone.
Thank you very much.
Nice to be here. Thank you. Bye.